Hello. Today I'm going to help you gain a better understanding of urinary incontinence, what it is, what you can do, and ways your doctor can help you manage it. First, let's make sure we're all on the same page. So, what is urinary incontinence? Urinary incontinence is losing urine when you don't intend to. You may have heard the term overactive bladder, which is sometimes used interchangeably with incontinence. Actually, overactive bladder is really a group of urinary symptoms, and it may or may not include incontinence. Incontinence can occur for many reasons. It is not an inevitable result of aging, although age related changes in our bladder and urinary structures can contribute. There are a few different types with different causes and treatments. We're going to talk about each one. But first, let's discuss how your medical team evaluates your incontinence. First, they will try to determine the type you have and how severe it is. They will probably have you keep a diary of voiding patterns and symptoms, such as having to go often, or at night, or having trouble getting the urine started. They may also ask you to complete a survey which measures your quality of life related to urinary issues. If you have incontinence, you know that it can be embarrassing and keep you from socializing and doing things you enjoy. They may order urodynamic studies. These are x-rays and videos which evaluate how well your bladder holds and releases urine. These tests are not painful, but they do require a catheter to be inserted. Your doctor may refer you to a urologist who specializes in urinary problems for this workup. So, what causes UI? Many medical conditions can contribute to urinary incontinence: an enlarged prostate, vaginal atrophy, neurological conditions such as MS or Parkinson's disease, or injuries such as trauma to the spinal cord, even urinary tract infections. The first step in managing urinary incontinence is to address the underlying conditions. There are also many medications that can cause or worsen UI, such as oral estrogens, diuretics, antihistamines, decongestants, narcotics, sedatives, medications used to treat high blood pressure, and others. Your doctor may choose to reduce or change your medications to help with your incontinence. You may be referred to a urologist for further workup if you also have abdominal and pelvic pain, blood in the urine in the absence of a UTI, a known problem such as a prolapse, neurological symptoms, or a history of pelvic radiation or surgery. There are things that can be done by anyone for any type of incontinence. These include lifestyle modifications, such as losing weight. Incontinence is more common in obesity, so try to lose weight if you are overweight. This is most effective in women with stress incontinence. Dietary changes, such as avoiding beverages that can exacerbate incontinence, are helpful. Things like alcohol, carbonated, and caffeinated drinks can cause diuresis or loss of fluid. You also want to avoid foods that act as a diuretic, such as watermelon, celery, and peaches. You want to limit your fluids to no more than 64 ounces a day, and especially limit them before bedtime. Taking measures to avoid constipation can also reduce urinary incontinence, since a full bowel can put pressure on the bladder. If you smoke, know that smoking increases your risk for incontinence, so try to attend or participate in a smoking cessation program. There are also exercises you can do called pelvic floor muscle exercises. These are easy to do and have proven to lessen urinary incontinence. These exercises are done by contracting the muscles in your pelvis as if you're trying to hold in your urine. If they're done consistently and correctly, they can be effective, but it can take 6 to 12 weeks to see improvement. So don't give up too quickly. They're most effective for women with stress incontinence, but they can be helpful for men and for urge incontinence as well. Bladder training is timed voiding, learning to void at regular intervals, and using pelvic exercises, distraction, and relaxation to help for the time in between voiding. This also can take up to 6 weeks. Finally, there's double voiding, where you void and then change your position, like standing up, and then void again. So those are measures that anyone can take to help with incontinence. Now we'll discuss the different types, what they look like, and what can be done. Stress incontinence occurs when you exert yourself by sneezing, coughing, maybe lifting, and urine leaks out. This is due to a lack of support at the neck of the bladder, which keeps that sphincter between your bladder and your urine tube from closing all the way. It's more common in women due to pregnancy, childbirth, and menopause, but it can also occur in men after prostate surgery. There are no medications specifically approved for stress incontinence, but for women with vaginal atrophy, topical estrogens can help. And there's a medication called midodrine, which is for people with low blood pressure. It happens to have the side effect of helping the urethra, that's the urine tube, to close better. This can be effective for mild to moderate stress incontinence, but it cannot be given to people with high blood pressure or with coronary artery disease or arrhythmias. The side effects of midodrine are hypertension, dry mouth, nausea, and insomnia. Antidepressants such as amitriptyline, imipramine, and duloxetine are also used off-label for stress incontinence. All these meds have side effects and contraindications. Your doctor will choose a med that's appropriate for your situation. Non-medication approaches for stress incontinence depend on, to some extent, whether you're male or female. For women, there are minimally invasive devices ranging from pessaries to various inserts for the urethra, for the vagina or the urethra. An intravesical balloon device is one of these. There is variable evidence about both the effectiveness and the safety of these devices. For men, the gold standard is the artificial urinary sphincter. This is surgically implanted. It is a silicone cuff that fits around the urethra, and a balloon regulates the pressure in the cuff, and that is controlled by the man through a device that is implanted in the testicle. And this allows you to deflate the cuff when you need to void and inflate it when you don't want to void. There are also male urethral slings, so providing additional support to the urethra, and that can be effective for mild to moderate incontinence. For men and women for whom these other measures aren't effective, there are more invasive procedures. There is the injection of bulking agents, which can cause, they act like almost like a filler agent to sort of swell up the urethra so that it completely closes. It's not as effective as surgery, and it may need to be repeated. Surgery is the most effective and best option for severe or persistent cases. Another common type of incontinence is urge incontinence. This occurs when the bladder spontaneously and unpredictably contracts even though it isn't full. The muscles squeeze so hard that the sphincter cannot hold back the urine, and you have an urgent need to void. You may not get to the bathroom in time. Causes range from bladder infections to an enlarged prostate, trauma to the nervous system, stroke, and other neurological diseases. Other symptoms that might go along with it are painful bladder spasms, nocturia, which is having to void in the middle of the night, waking up to void, and painful urination. The approach for this kind of incontinence, outside of the lifestyle modifications we mentioned earlier, is medications. There are a few major groups that are used. The first one are called antimuscarinics, and the goal of these are to relax the bladder so that the random spasming does not occur. Some of these meds, what we call the first generation antimuscarinics, are oxybutynin and tolterodine. These have a modest effect. They won't resolve all the symptoms, and they can take 4 to 12 weeks to see a change. If one doesn't work or the side effects are uncomfortable, another one can be tried, and there are both immediate and extended release forms. These meds are what we call anticholinergic, and their side effects are dry mouth, constipation, blurry vision, drowsiness, rapid heart rate, and decreased mental function. Some people cannot take these medications, and they are also not recommended in the elderly. Additionally, there are many medications that will affect how these particular drugs work, so your doctor needs to know everything that you are taking. The second generation version of these meds have less of those same side effects. Some of those are called Sanctura, Toviaz, and Vesicare. Another category, and it really is only one medication in this category, is the beta-3 adrenergic medications, and it's mirabegron. It has some similar side effects as the antimuscarinics, but less so, less dry mouth and constipation. However, it can cause high blood pressure and headaches, dizziness, and UTI, and irritation of the nose and throat. These meds are better for people who are elderly, but cannot be taken by those with high blood pressure. Often your doctor might prescribe meds from both categories if one isn't working well enough or is causing significant side effects. An antidepressant, imipramine, is also used for urge incontinence. Because the medications used for urge incontinence cause urinary retention, the amount of urine left in your bladder occasionally has to be measured by the doctor. This is called a post-void residual. It's best done by inserting a catheter, but a bladder scanner is a non-invasive way for them to get an idea of how much urine is in the bladder. Besides medications, urge incontinence can be addressed through acupuncture, tibial nerve stimulation, which delivers stimulation to a nerve behind the ankle, and multiple sessions are required. Both of those are short-term solutions. Sacral neuromodulation involves the implanting of a device like a pacemaker into the buttock, which delivers electrical stimulation to the nerves that are involved in bladder contraction. Botox injections, with the same Botox that is used for cosmetic purposes, are used for the bladder muscle and act as a muscle relaxant. They can take 3 to 6 months for effect, but can be very effective. They can cause urinary retention and UTIs. Finally, the most invasive options are surgery. Different types of bladder surgeries and diversions can be done. Mixed incontinence is a combination of both urge incontinence and stress incontinence features. So the treatment will depend on what symptoms are most prevalent. The last type of incontinence is overflow incontinence. This is related to chronic urinary retention. Damage to the bladder wall can cause the bladder to not tell the brain when it's full, so the bladder never really empties completely and gets stretched out like a distended balloon. The contractions become weak, and ultimately it ends up too full, so it overflows. overflow incontinence. This is more common in men, but it can occur in women due to a prolapsed bladder or uterus. The main two causes for overflow incontinence are what we call a hypotonic or a neurogenic bladder. And this is where the bladder has low tone, it's weak, and it does not contract correctly. This can be caused by diabetes and neurological problems. It can also be caused by medications that cause urinary retention, such as some narcotics, some antidepressants, and the meds we spoke of earlier, to treat urinary incontinence. Bladder outlet obstruction is the other main cause of this kind of incontinence. And this is caused by anything that blocks the urethra or blocks where the bladder meets the urethra. So an enlarged prostate is a major culprit. Any type of urethral stricture, tumors which press on the urethra, and organ prolapse. Other symptoms that are present with overflow incontinence include trouble starting a stream, a weak stream, hesitancy or a sense of not fully emptying your bladder, that nighttime urinating, frequent urinating, and dribbling. So the treatment for this depends on the cause. If it is a hypotonic bladder, there really are no medications. The sacral nerve stimulation may be helpful, but often intermittent catheterization or long-term indwelling Foley catheter is going to be needed. It's important that there be a meticulous technique used when catheterizing. If the cause is an obstruction, as in an enlarged prostate, there are a few categories of meds. The first are the AABs, alpha adrenergic blockers. These are used for moderate to severe symptoms and are effective within 5 to 7 days, so they're often used first. There are two categories, non-selective and selective. The ones which are non-selective also lower blood pressure, so there is a risk of what we call orthostatic hypotension, when the blood pressure drops too low when you change position, along with dizziness, fatigue, tachycardia, which is a high heart rate, flu-like symptoms, and gastrointestinal symptoms. One particular med in this category, terazocin, also can cause a condition of the eye which can result in permanent vision loss during cataract surgery. Other meds in this group are doxazocin and prazosin. The more selective meds in this category are not going to impact the blood pressure as much, though it still can have an effect. One of the most common med in this category is tamsulosin or Flomax. There are multiple side effects with this medication as well, including changes in sexual function and again, flu-like symptoms and insomnia. Another category used to treat the BPH, the enlarged prostate, are ARIs. These are alpha reductase inhibitors, and the most common ones are Avodart and Proscar. Now these can take up to 3 to 6 months for full effect. They're often used along with the AABs. And if somebody has, in certain situations, they may be used first. These can cause sexual problems or impotence and increased breast size or breast tenderness. Again, very often combinations of these meds are used. Another med is called a PDE5 inhibitor, tadalafil, and this stands alone in its category as being effective for those lower urinary tract symptoms and for erectile dysfunction. So what non-medication things can we do for overflow incontinence? Well, there's various ways of doing prostate resection, an open prostatectomy, a transurethral, and the least invasive is the laser version. There's also um, mechanical devices that can be used to help support structures that are prolapsing or falling down and putting pressure on the bladder and urethra or obstructing it in some way, such as pessaries. Surgery may eventually need to be repeated, but surgery can also be done, whereas pessaries are need daily maintenance. So there's pros and cons to each of these options. And finally, how can you manage incontinence day to day? Well, firstly, you want to look at your environment. If the bathroom is not nearby or it's hard to get to, you want to make sure you have a bedside commode or urinal. There are external catheters for men that are an option. You want to make sure you have easy to remove clothing and the right incontinence products. Urine on the skin can cause irritation, breakdown, and superficial infection, so it's important to maintain good hygiene and use a skin protectant, a moisture barrier in your peri area. You want to maintain your function so that you can get to the bathroom through regular activity, exercises, and physical therapy. And once again, if you're doing intermittent catheterization or have a long-term catheter, you're more prone to urinary tract infections, which can worsen incontinence. And so you want to make sure you're using a meticulous technique. The take-home message is this: keep your doctor informed of changes in your urination, even if they're only mild changes. They could be a sign of an underlying condition or put you at risk for other problems, like a kidney infection. We also want to know whether the medications and interventions that we have prescribed are working. So please keep us informed so we can help you manage your incontinence. Thank you.